Yeah, I would like to thank Dr. Khan and the APVIC community to allow me to be here again, even though it's online, but I wish I could be in Delhi again. Okay, my talk today is saving iron manhood, and we will come to what I mean by this. Is my patient is a 67 years old gentleman who is a smoker with hypertension and dyslipidemia, and came with a stable ischemic heart disease and had a PCI to the right coronary artery and obtuse marginal in 2019 with a good every ejection fraction of 55%. He also has a chronic kidney disease with the eGFR of 32 mils per minute, and he's asymptomatic. Now, we incidentally found a triple A abdominal aortic aneurysm, which is 6 centimeter at the largest diameter. I will show you the CT angiogram shortly, but is going to show you a tortuous iliac with a neck angulation of almost 90 degree, pararenal neck, and bilateral common iliac aneurysm. So this is the VRT images of the triple A that the patient has. Now, one look at that, you would know that this is probably a surgical candidate from the start. Even though the size is more than 6 centimeters, but as you can appreciate here, the neck, the neck is definitely not for any intervention. In fact, there is no, not any IFU for any types of devices that we have, unless we're going to go above the renal artery and do some kind of a chimney procedure to bilateral renal arteries. And if you see here at the iliac regions, the right common iliac is huge, and the left as well is enlarged. And the other problem that we'll be having is the tortuosity of the iliac arteries. This is the CT angio on the axial cuts. I will bring you to the abdomen. If you can see here, the descending aorta is slightly diseased, not too bad for a 67-year-old gentleman. There's some atherosclerotic diseases at the descending thoracic. But as we go down at the renal artery level, you can see here that it is almost horizontally moving towards the right side. And this is the scary part if we were ever to do anything for the triple A. The size, like I mentioned, is 6 centimeters and it warrants intervention. And if you go down below to the bilateral common iliacs, you can see both are aneurysmal, with the right bigger in terms of lumen size compared to the left side. And as we go down to the iliac bifurcation, it is also disease on both sides. And in fact, you can see the tortuosity until it reaches the common femoral artery. Now, the problem with him is that he is not keen for any kind of open repair. And furthermore, he had a PCI recently, and he is also on double antiplatelets. So to me, endovascular aortic repair using stents is technically challenging, like I mentioned earlier, because of the elevated neck, pararenal, and really needs bilateral renal chimney. And we probably also have both internal iliac artery. And the other option is to preserve on one side. The type EVA device is also important because we need to do crossover if we ever want to do anything for the iliacs. And my only option here is by using an endologics device. The procedure was performed after discussing with our surgeons. He went under general anesthesia. We have both femoral artery pre-closed with ProGlide closure devices, and we use endologic AFX device for the triple A. The EVA limbs were extended bilaterally into both common iliac, and we think that if to secure a sealing at the neck, we may have to consider extension and renal chimneys. These are the images of the tortuous iliacs on both sides. And then this is the main body of AFX deployment at the aortic bifurcation, sitting right on the bifurcation itself. By using this AFX device, we can still go crossover even after we deploy our stents. Unlike some other stents that causes us not to be able to go across. This is the neck angulation. As you can see, we have already deployed the main body, and we are now poised to put another device to the top. But surely you can see on the right panel, the stent is not exactly below the renal artery, the extension device, and it failed because of the 90-degree neck angulation. Surely on the left side, we tried to post dilate, and despite doing so, the stent that we extended at the top fell into the aneurysm sac. So we have no option but to actually to go with bilateral brachial access for renal chimneys. We had a big graph cover stent, 6x50 on both renal arteries, and we extended the EVA stent further up, vanilla EVA extension, and subsequently we did a final thing. So this is the extension, as you can see here, which we finish off with a kissing subsequently with all three balloons in the two renal arteries and the main artery and the main aorta. In this is to show you how we post dilated the aorta. And now we have to do sparing of the iliac artery. Now, because the aneurysm is so much huge compared on the right side compared to the left side, we decided to do an internal iliac coiling right away from a left crossover technique, and subsequently the left internal iliac was stented using B-graft 10x57 with a snorkel technique into the left iliac artery. This is a challenge because we have wires for the main device from the left renal artery, from the left femoral artery, and using the same sheath, we have to put in another wire to pass in our B-graft from the left common femoral artery into the left internal iliac artery. And subsequently, we extended both limbs into respective external iliac arteries. So this is the right side. If you see there, we went crossover from the left side. We packed in a sheath and subsequently a GR catheter, and we put in coils into the right internal iliac artery, and subsequently we extended the EVA device on the limb. And this is the left side, which we had difficulty earlier, but we managed to put in a stent from the left common femoral artery into the left internal iliac, and subsequently we extended the left endovascular device AAA limb into the left external iliac artery. And the final result, there was no endoleak. However, because of excessive blood loss due to sheath issues, we need to transfuse some 6 pints of blood. And this is the final result. From the top, as you can see, there is both renal arteries which are preserved, and there is no endoleak from the top. And that is the second panel in the middle is the final result of the left side with, if you can appreciate, there is still a flow in the left internal iliac artery. However, there's some endoleak here on the right side, and subsequently we extended further into the right external iliac artery with another stent. So all in all, he had a chimney procedure for both the renals, and also I would say a snorkel procedure for the left internal iliac artery, while we coiled right internal iliac artery. However, the problem is with us actually, because it took us a really long procedure. It's a 9-hour procedure, a lot of contrast use. There was acute kidney injury. Already he's having a chronic renal failure to start with. We went up to 430 micromole from 170. However, he resolved baseline after a couple of days. He was given antibiotic and discharged on dose of day 9. He was well on our follow-up. The serum creatinine went back to baseline, and we do not have any CTA yet, but we may alternate with ultrasound to look at the AAA set size and to look for endo leaks as well subsequently. So what I learned from this case is that it is a very complex anatomy involving IFU, which needs careful planning. Obviously, this is not a clear-cut case, which is also probably challenging for surgeons to do, but definitely since the patient refused for open surgery, we had no choice but to bite the bullet and carry on. The stage procedure may be considered, coil of the right internal eyelid perhaps to be done earlier so that we can have a shorter main procedure for the EVA. Of course, open repair will be stress again for the patient. And finally, on our side, there must be persistence for us to continue to proceed with this case. Thank you very much.
Congratulations, Shaiful. I think if you weren't an Ironman before the operation, after 9 hours of doing what you've done, you're certainly declared an Ironman now. I enjoyed watching the endologic graft go in at the beginning because it was, of course, developed at Arizona Heart by Miles Douglas and Dr. Dietrich many, many years ago in the 1990s. And it is a very slightly stiffer graft than some of the other grafts around now. In Europe, we have a couple of devices which are CE marked for 90-degree angulation. I don't know whether you might have thought about using another device. My main question is, would you have done this slightly differently in retrospect? Might you have done it in any way differently?
Well, like I mentioned in my last slide, I will probably do a coiling early on the right side and just concentrate on the procedure and start off with with an idea of doing the renal chimney as well. But surely with this couple of things, it's going to take hours. I believe I was prepared for this actually when we did it.
Yeah. Sometimes certainly I like to do the hypogastric coiling a week or two before the procedure, and yet I do notice you used very little contrast despite the length of your operation. But I think great congratulations on getting a fabulous result at the very end, and very well done indeed.
Thank you.
Thank you, Shaiful, for a wonderful case. I don't know if Dr. Reed can correct me. If we had the other dedicated grafts for these angulated necks, probably we would have been better off, especially the dedicated devices for the short neck and angulated neck and sac sealing devices.
It's just possible that they're not available to Shaiful in Malaysia just now, but yet certainly in Europe we have two I can think of just now that would have perhaps been helpful. It was originally a Gian Turco Z stent that Miles Douglas and Dr. Dietrich started with the power link in the endologics. And the stents that are used, they are slightly stiffer. They don't go around the corner so well as the more hooped stents of an AR-Fix or a Vascotec Anaconda. So it's been a good result in the end, and I think that's what matters, and a very good Ironman case.
Thank you, Shaiful, once again. And the last contestant is Dr. Girish Varavadikar, a very close friend, terrific interventional radiologist from Mumbai. And he is like one of the most active interventional cardiologists, does everything from neuro interventions to peripheral interventions, vascular interventions. So, Girish, welcome.